Good evening and welcome to one and all. I'm Ankita from Planet, the assigned moderator for a seamless experience. And Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Eastern India Zonal Ophthalmological Congress. And topic of today's session is Voice of East 2023. Let's begin today's session, for which I would like to invite Dr. Swarat sir to take over. So over to you, sir. Kindly proceed.
Good evening, everybody. From IOL Secretariat, we are here again together for being a part of the webinar Voice of East 2023-2 Part 2. The Voice of East is a platform for the young generation to come up with academic activities, and with this type of program, the bonding between different IOC states are tightened. Through IOC, our Eastern India is gaining its position and repute in the National Ophthalmic Forum and beyond. We'll be doing this webinar monthly, covering all the important topics, and will be conducted by the IOC members of the different states in rotation. For this year, the convener of the program is Dr. Devashish Das from Kolkata, and webinar for the month of July will be done by the Assam State Coordinator, being Dr. Hoimanti Chaudhary. Today, we had a very interesting topic, building up your PHAKIC IOL practice, where we had galaxy of speakers of national and international repute. The masters of the subject to mention, Dr. Kasturi Bhattacharya from Guwahati, Dr. Duel Biswas from Kolkata, Dr. Devi Aishwarya Das from Odisha, and Dr. Jaya Nath from Silchar, Assam. Whereas panelists Dr. BP Kashyap from Ranchi, Dr. Narayan Bardoloi from Jorhat, Rajan Gogoi from Dibrugarh, and Dr. Subhas Prasad from Patna, and Dr. Ashok Nanda from Bhubaneswar. Chairperson being Dr. R.C. Meher from Odisha, Dr. Ranjana Kumar from Patna, Dr. Shubhra Kinkar Goswami from Guwahati, and Dr. Arup Bhomik from Kolkata. Chairpersons and panelists are also stalwarts in their respective field, covering different IOC states and beyond. The whole session is being moderated by the dynamic young personality, Dr. Mayur Datta Bhairali from Nalbari, Assam, and Dr. Tirthojit Maitro from Hazaribagh, Jharkhand. And lastly, we had Dr. Praveen Shubudhi from Odisha. With the full support and guidance of our President, Dr. B.N. Gupta, and CSC, Dr. Sabyasachi Patnaik, our team is ready with the webinar for the month of July. Lastly, we extend our invitation for the annual conference to be held on 4th and 5th November at Hazaribagh, Jharkhand. We are expecting a great show there. Thank you so much. And just after this, we'll have a very small EIZOC video. So with this, I end our EIZOC video and over to our president for his presidential remarks.
Thank you, Suraj. On behalf of the entire EIZOC family, I welcome all the participants of this great program, Voice of East, which we have been conducting since a year or two. This is a very important topic because patients with high myopia, when the corneal procedures cannot be done, so PHAKIC IOL is the answer. And I'm glad that this topic has been chosen for today's webinar. I welcome all the chairpersons, the program coordinator, Dr. Devashish Das, the moderators, all panelists, speakers, Dr. Kasturi, Dr. Doyle, Dr. Devi Aishwarya Das, Dr. Jayanath, and Dr. Hemanti, the state coordinator of the program. So I'm sure this program is going to be very enlightening and will be of immense helpful to all the participants, maybe the faculty or the audience. So on behalf of again the EIZOC family, I welcome you all and wish this program all success. Thank you.
Now I think over to Dr. Hemanti for the continuation of the program. Dr. Devashish, they will hand it just after the introduction. They will hand it over to the moderator to continue with the session. Over to Dr. Devashish and Dr. Hemanti.
Okay, thank you.
I think Dr. Swara in details of the Voice of the East program. It is on me. May I Dr. Hemanti, please.
Yes, thank you. So I think without much ado, I will straightway hand over to Dr. Mayur Datta Bharali to start the first talk. Dr. Mayur, please.
Yeah, thank you very much, Dr. Hemanti. So today we have a very good topic of building up our PHAKIC IOL practice. Can you hear me? I guess.
Yes, yes.
So we have a thank you. So we have a very eminent person as our panelist in this talk with Dr. Narayan Bordloi, Dr. B.P. Kashyap, Dr. Rajendra Nath Gogoi sir, Dr. Ashok Nanda, and Dr. Subhas Prasad. So our first speaker is Dr. Kasturi Bhattacharya Madam. She is Director Clinical and Academics of Sri Shankardeva Netralaya, Guwahati. She also heads the Cataract and Refractive Surgery Department together with Orbit Oculoplasty Department also. So she will be speaking. On optimizing the outcomes of PHAKIC ICL. So please, Madam, you can start your deliberations.
Thank you very much, respected President Sir, Dr. B.N. Gupta Sir, and the Secretary for EIZOC, and also Pranab Ranjan Sir, whom I really have very high respect. Respected all the seniors, all the members, and thank you for this opportunity. So it's really a great honor for me to be speaking today in this forum. So I'll be speaking on, can you see my slides?
Yes,
yes, Madam. Yes, yes.
So I'll be speaking on optimizing the outcomes of PHAKIC ICLs. So when we call PHAKIC ICL, it is basically an intraocular lens that is placed inside the eye in someone who still has a natural lens and who are called PHAKIC, and they can be used for correction myopia, hyperopia, and astigmatism. So when we call about the different types of the lenses, intraocular lenses for the correction of the refractive errors, it started with the anterior chamber lens. Then we also have the angle supported. We also have the posterior chamber. But what today I'll be speaking is basically the posterior chamber, which we classically call as the PHAKIC ICL. So this lens has a very interesting component. It is made of polymer and it really offers a very excellent quality of vision. So this is basically an optical zone, and also it has got a haptic. This optical zone is much thinner. It is approximately 50 micron. So if we look to the hair, our hair is approximately 30 micron. So it's as thin as just 2 strands of hair. And this is a thicker part, which is approximately 100 micron. And you see the holes here. The holes have a specific size, that is 360 micron. This is because it helps the flow of the natural aqueous. And the most important, like when I was also questioning why it is not 400, why it is 360. So multiple studies has been done, and they have found that when the hole size is 360, the chance of having spherical aberration is much less. So these lenses are used for a wide range of refractive error. And it is basically made of a combination of collagen and a copolymer, the copolymer being the HEMA. So most important, we all know that all the intraocular lens, whatever it is, we want it to be biocompatible. But the advantage of this lens that it attracts fibrinolactin. So what is the advantage of having a fibrinolactin? It is that it inhibits the cell adhesion to the lens, and so there is no foreign body reaction. And if you look here, this is an electron microscopic photo where they have shown that the collamer lenses, even then when they're exposed to protein, they do not show any deposition of the proteins. But if you look to any of the acrylic lens in a very high magnification of 100,000 times, they show a very high dense protein deposition. Moreover, there are also studies who have shown that these collamer lenses have an excellent quality of vision as compared to even that of the normal lens. But this is a study in the aged eye. So what we do need to do a preoperative planning. We have guidelines that it should be done above the age of 21 with no previous corneal refractive surgery. Anterior chamber depth is 3, but sometimes we can go up to 2.8, especially in case of hyperope, like we know the ACD is much less. Stable refraction and accurate measurement on the wide to wide. Different ways of doing wide to wide, but I usually prefer the digital one. And this is always I like showing you because I started this procedure way back in 2007. And this is my first patient who came to me with a power as high as 20. So he was minus 20. He was so introvert, having such a negative way of living. Then when we suggested him, and what really made me happy is the quality of life change that I had seen. So after that, when he had grown up with a phakic ICL, now today he has his own business and he has developed a much better quality of life. The negativity is not less. So that is not only the improving the quality of vision, but also it helps improve the quality of life. So at that time, when we were doing the phakic ICL, there was no hole. It is they do not have the center flow ICL. So in every patient, we need to do a peripheral iridectomy, which was mandatory in order to prevent. So if you look out here, there's no center hole, but now they have modified it and they have come with a center hole. So initially when we started, we used to follow the patient. We used to see them initial 2 hours, 4 hours, we need to see the one thing. But nowadays with the digital caliper, at that time we did not have the digital caliper. We used to do either with the UPM or the standard caliper. So the chances of what we see, this chances of having a wall issue was much there in the initial days. And then now what we have now, we have a much modified version, which we call the center flow. Advantage of center flow is that multiple holes, 3 in the optics and 2 in the haptic. And the leading haptic, that is the superior haptic, the hole is in the superior right side. So it is towards the right side in the leading haptic. And the advantage of this hole, so this hole really helps us to prevent the postoperative or the intraoperative iridectomy, which initially we used to do. So lesser the touch to the iris, it is always a better. And this is again under the lens that you can see here, that is being used, as you can see here. So what is an ICL wall? It is basically the distance between the anterior lens surface and the posterior surface. And we need an adequate wall of, I think half is less. I think it should be 0.75 to at least 1.5. And what happens if it is undersized, it is flat. So every chance of touching the lens and leading to subcapsular cataract. And if it is oversized, there's always a chance of glaucoma. So most important, the sizing of the lens is very important. And along with this normal spherical, the toric lenses have come. And the toric lenses are very easy because they usually do a calculation such a way that you need to mark the 180 degree and either you rotate some clockwise or anti-clockwise. So this is how the toric has also helped us in correcting the cylinder in such patient. And then as you can see here, this is the mark out here. And then wherever you have marked it where the axis needs to be placed, then you place it accordingly. And in my practice, I have not seen toric rotations, but some I have heard previous speakers, some of the speakers feel that there has a rotation, but I think if the sizing is proper, the chance of rotation is minimal. So these are some of the cases where I feel with the advent of the toric, like we can go for a much better holistic treatment of all the refractive error, whether the patient has got spherical component or a toric component along with it. So now we have the EVO Plus. Advantage of the EVO Plus is that the diameter of the optic is larger. So this has decreased some of the earlier side effects like all the photic phenomenon like the glare, the halos, and the high order aberration. Especially useful in myope patients because we know the myopes usually have a larger size pupil. So besides talking about a collamer lens, now what has come to the market is another lens, which is the PHAKIC lens. I have got very limited experience. I have done only in 2 eyes, but I feel this is also a good lens, but I cannot comment much because, but what I have seen many of my friends who has very recently, I have met one of my friends from Delhi. She reports that she had used more than 35 of these lenses and she is happy with the lens. The design is same, only difference is that the leading haptic, the hole is towards the upper left. So this is also one of the ICL that has come and is much cheaper as compared to the star ICL that we have been using. So these are the long list of complications, like any of the surgery we can have a complication. But what I have seen basically is, yes, sometimes you see high IOP either in the early post-op or late post-op. Late post-op is maybe because of steroid induced. I have seen changes in my hand also low wall, high wall. Cataract I have seen in many of my patients, especially those early days when we started in 2007. So after 15, 16, 17 years, there are cataract. And also one complication I have seen, I think I got 2 or 3 referral with this, where the lens has been placed upside down. So this is where you can see when you document with OCT, you can see the lens being placed upside down. And then these are the cases you need to explant it and then replace it. So low wall is also one of the common, especially when you have, smaller lenses, the sizing is not appropriate. You can have a low vaulting. So if you have a low vaulting, the most important thing that, is my time over, Hemanti?
No, ma'am, you can.
No, ma'am. No, ma'am. You can
you-
please finish. Yes,
Just
yes,
I'll
yes.
finish
Ah,
in
ah.
1 to 2 minutes. So you need
Yeah, ma'am.
plant when there is a low vaulting, and then you can also go for a replacement of a bigger size lens, as you can see. So because it's a thinner lens, the explantation is not much of an issue, and I hardly you need to increase it. But if you want to increase, I usually, though the company says that it should be 3.2 millimeter, the entry, I usually keep it same like 2.75. I have never used 3 millimeter. And then only if you need to explant, I make it a little bigger, 3.2 or 3.5. So you can explant it and also replace the lens if you have this undersizing. You need to inform the company. And like you can see, this is a very low wall. You can see hardly, this is not even less than a half corneal thickness. And this is a day after exchanging, you can see the vault is much improved. So vault is basically this distance, the posterior surface of the ICL to the anterior surface of the lens. So with the vault, if it is appropriate, the chances of having a late, cataract is less. So this is one of the patient where you can see the patient had the anterior subcapsular cataract, and then the whole of the lens was explanted. And these are patients are very high myopia. So after explanting, you go for the cataract surgery. And the cataract surgery, once we do, the cataract is also not very advanced. You need to put the 3-piece lenses because these are very, very high myopia. You need to place a much higher powered lenses. This is another patient where you can see there's a cataract cataract has developed, and then you need to explant the ICL. Explantation is not an issue because you have the hole. Look at the iridectomy here. So these are some of my old patients where we used to do 1, 2, 3 iridectomy with a fear that the patient will develop glaucoma, but more than glaucoma, the patient had cataract. But this is okay. Like this patient will be now in his 40 years. Otherwise, also we know myopia, the chance of developing cataract is much higher. And so after the lens was being implanted, then we had done the cataract surgery. I had done the cataract surgery. And then you can see a much higher per 3-piece lens has been implanted. So these are some of the complications. And before I conclude, I'd like to mention they can correct the degrees of the high degree of refractive error can be performed in patients who are not a good candidate for LASIK, especially those patients having thin cornea or having issues with dryness or very high cylinder. And also nowadays we have the larger optic design, so it has really helped in improving the quality of vision. So with this, I thank all of you for giving me this opportunity, especially Haimanti for asking me to present this topic. So thank you all very much for the patient hearing.
Thank you, madam. It's a wonderful talk. So one thing, if we can have a few minutes of discussion also. Yeah, so one of the initial complications with the ICL was that you already mentioned at the turning of the lens upside down during implantation. So what do you think it has changed in the further generations, or what do you do to avoid that, or yeah?
Yeah, this is actually, when you take out the lens, when you see in that bottle, no, you see
Yes,
the
ma'am.
way it is placed, and when you take out with that kuchi type of that thing, no, so
Yes,
you
ma'am.
see that the convex is upwards.
Mm.
And when you place the lens inside, when it unfolds, then also you should keep looking whether the convex is opening upwards or not. That is the time where sometimes this issue might happen, where the convex may be towards the lens side. So that orientation, when you first place the lens in the cartridge, you should be very careful that convex should be facing upwards.
Right. So,
Is it-
doctor,
no,
yeah,
the-
yes, ma'am.
yeah.
Continue, ma'am. Yes, ma'am. Tell me. Yeah.
No, the lens itself, you can see when you take out the lens from the bottle, you'll see the lens has a curvature with a convexity upwards. So in this position, you need to place in the cartridge.
So we have also in our panelist the eminent Dr. Narayan Bordloi sir, and we know that he in Northeast he is one of the pioneers of putting ICL. So if sir can add something regarding this, Bordloi sir.
Narendra, I think you're muted.
Narayan Bordloi sir, you are muted, sir.
Yeah. Can you hear me now?
Yes, sir. Yes, sir. Yes, sir.
Yeah. ICL, I think it is the best thing in high myope cases where you cannot do LASIK. And result-wise, it is much better than LASIK because you do not touch the cornea. You just put the lens in. So all those bad things in LASIK are not here. And about my cases, I did a lot of this ICL. I put only ICL, never I put IPCL.
Yes, sir.
And well, all the cases were good, except one case, like Costa one case, it was upside down.
Yes, sir.
And I put the patient, I had the feeling that this may be upside down, but I closed the eye, and next day, when I examined the vision, it was 6/9. I thought it may not be upside down. So I went for the next eye next day, and that eye 6/6 vision. But the patient is very happy, but she is complaining that he sees her right eye is not as good as the left eye. So I was not thinking that it was upside down. Then I sent the patient. Then she came back with severe pain in that. We did the anterior chamber OCT. We found that this angle is all obstructed. And now the problem is that the lens I can take out and put in with upside normal fashion, but I didn't have a cartridge. So I fanatically rang to the ICL people to send me a cartridge. They sent the cartridge back, and in 2 days, 3 days time, I got the cartridge, and with lot of heavy heart, I took out the ICL, put it in the new cartridge, and fortunately, I could put it in the proper way. And from the very next day, the patient is all symptom-free. So that is one thing we have to be careful. That is the only thing difficult in ICL is putting the lens without upside down. And that is the only thing. If you overcome that, then ICL is very easy.
I'll just add one point to it. In ICL, since these are all customized and you get only one lens, so always before opening the eye, you should be very sure that you take out the lens, put in the cartridge and keep everything ready. God forbid, supposing the lens falls down or there's a tearing, once the eye is open, then that will not be very justifiable. So this is one thing, since this is customized, only one comes for one eye.
Yeah, you are correct. And I also do that. Yeah. And otherwise, ICL is a beauty.
So I'd like to request Dr. Tirtha to kindly introduce our next speaker.
Can I have a question to Dr. Kasturi?
Sure.
You said that it can create cataract in some cases, but a lot of speakers in the national level, they say that if there is an initial cataract, you just remove the lens and the cataract regresses. What is your opinion about this?
Actually, I have seen cataract in those early cases that was done, like where there was no center flow and we used to do peripheral iridectomy. And these cataracts are ones, I don't think, because only cataract which comes, which disappears are when you do sometimes during a vitrectomy procedure. But this cataract occurs for multiple reasons. Number one, the nutrition gets hampered. Number two, there's a contact. So I don't think, in my experience, I have never done like taking the ICL and keeping them without the ICL with a belief that the cataract will regress or remain stationary. I don't have that experience. But when I see there is cataract affecting his quality of vision, so those are the patients I take out the lens and I do the cataract surgery.
No, my question was, if there's the initial cataract, when it's on the follow-up, when I see that the patient is developing cataract in initial stage, people say that you just remove it, the cataract becomes all right, it regresses by itself. But you do not say, you don't have this kind of experience.
No, sir. The patient who comes to me, they say that I cannot see now without the with the ICL. Then I see by the time they had come to me, they have good amount of cataract.
Okay. So regression of cataract, you don't believe in this?
Dr. Kashyap, I have one patient. I'm Ashok Nanda from Bhubaneswar. One patient whom I had to remove because the fault was about 110 microns. That patient had about you can say anterior cortical cataract. Still the vision was 6/9. This patient has been with me for last 3.5 years, and the cataract has remained the same, and the vision is still 6/9 with the contact lenses.
No, my question was different. The patient is happy, is no problem. But my question is, when people say that the cataract regresses when you remove the ICL, that was the question.
In 3.5 years, it has not regressed.
Okay.
Sir,
I also agree with you. Yeah.
Can I say something, sir? Hello.
Hi, Savas.
Yeah, sir. Sometimes there can be, sir, just aqueous after surgery, which actually goes with time. These situations may sometimes it looks like cataract, but sometimes there is just entry subcapsular aqueous, which with time subsides. So that is one of the cases where it can regress. But eventually, I have not seen any case regressing. And then regarding incidence of cataract, which is more seen when the initial myopia is more than 15 diopter and the axial length is more than 30 millimeter. Those cases are more known to have progression or onset of cataract early.
And so regression of posterior subcapsular cataract can occur. There are reports in diabetes. When there's a very early posterior subcapsular cataract, regression has, or there are few reports, sir. But regarding ICL cataract developing, removing the ICL and regress has occurred, sir, I have got no idea about it, sir. No experience, sir.
I agree with you, Dr. Kasturi.
I think we'll go to the
high diabetic. There, when the cataract appears and once the diabetes is controlled, there you can have regression of cataract. But otherwise, as such, I don't think we can have regression. Thank you.
I think the pathogenesis doesn't allow the cataract to resolve in that way, na? Pathogenesis of developing cataract. probably.
Only diabetic cataract, what we read, sir,
Yeah.
diabetic cataract, and we
Yeah.
have seen also early diabetic cataract with a control of blood sugar, it's stationary or it might regress provided it's just early PSC.
Okay, may I have a second question, Dr. Kasturi? My second question is, when you go for the star people, they give you just one lenses. You go to the IQ people, they give you two lenses, one for the spare, something goes wrong. So I don't know. I'm really afraid when I just have a single lens. So it's so comfortable mentally. You're at a peace. You have got a second lens. It can be get jammed into the plunger or whatever. It's anything can happen. So it is always have to have a one spare lens. That is so soothing to your brain and for mental peace.
Yes, sir.
So could you just move on to the next moderator,
speaker.
please? Tirtha, please take over.
One question, Dr. Kasturi ma'am, excellent presentation. Just wanted to ask, what problems did you face, like initially once you began with this journey of this ICL? So what were the with PHAKIC IOL, what problems initially you encountered for a beginner?
My first problem, I think that is the only early problem, is a vaulting problem. At that time, we did not have the digital caliper. We used to take the standard caliper and we used to measure. Sometimes we used to do with UBM also. So there was a, I at least remember my early 2, 3, not even 2, 3, yeah. Patient 1, 2 for very high volt and 1 for a low volt, I had to remove it in my early days. But the company people were very helpful. Immediately, they had given it free of cost. That is one I have realized. And second problem, that is the only problem I have encountered. Oh, two girls developed steroid-induced glaucoma. So you need to see the patient in the early days also. So I follow, supposing I do it today, next day, 1 week, and then 2 weeks, 1 month. Only when they are under the steroids. To develop steroids.
And do you think the chances of RD in these myopics, whether we do LASIK for whether the chances are more with LASIK, or the studies are few studies show that it's almost equal, and sometimes a small series are there. What's your take on that, regarding the chances of retinal detachment, and in cases if we
I see the chance should not be more, because you need a very good examination of the retina, and if you're sure that there are no pre-existing traction of breaks, the chance should not be more. In fact, and when I do femto or the LASIK procedure, the suction when we put, that is a more fear to me than the ICL in a high myopia.
Tirtha, please
Yes,
introduce the second speaker.
So now I'm going to invite Dr. Doel Vishwas. She will be speaking on IPCL, a road to glass-free life. Dr. Doel Vishwas is senior consultant at Shushruth Eye Foundation and Research Center, and her specialty is cataract and refractive surgery. Please, ma'am. Please.
Good evening, and thank you so much for having me here. Basically, most of what I intended to say has already been covered by Dr. Kasturi, because whether you're doing ICL, IPCL, I think the basic fundamentals are all the same. But I am going to talk about IPCL, the basic reply to ICL. And I started off my refractive career doing ICL, that at that time the IPCL did not have the central hole. But ever since the newer version 2 of IPCL has come out with the central hole, with the vault a little more, and with all the other innovations, I have almost switched over to IPCL, unless and of course my patient wants a foreign lens. So just bear with me. I am not at all tech savvy. So I'll just go through these initial slides. That's not required because it has already been covered by Kasturi, Dr. Kasturi. And I'm going directly to the IPCL. What are the characteristics of an IPCL? The IPCL is inserted through a 2.8 millimeter incision. It is customized to shape and size of the lens eyes. The correction range is from a plus 15 diopter to a minus 30 diopters, and the cylinder is up to 8 diopters. And the material is a hybrid acrylic material and no porcine polymer, unlike the ICL. And this matters in countries where you have certain religious restrictions. So what is the criteria for doing a phakic IOL, whether ICL or IPCL? For me, it's usually the age above 18 years. Refraction has to be static for 1 year. Unsuitable for LASIK. Now, this is a very debatable point, because there are a lot of surgeons who are saying that now the phakic IOL is much safer than the LASIK. So why are we doing the LASIK? Why not do the phakic IOL? At the end of the day, it is reversible. But I believe what most refractive surgeons still follow is going for the phakic IOL only when we cannot do the LASIK. The anterior chamber depth has to be 2.8 millimeters. Less than that, there is always a chance of glaucoma, and the cell count more than 2000. Among all there are a lot of contraindications, but I think the main contraindication for doing a phakic IOL is when the anterior chamber depth is less than 2.8 millimeters. That is a strict no-no for me. Power range, as I've already mentioned previously, it has a very, very wide power range. I have done up till minus 25 diopters. And you also have the presbyopic IPCL with from minus 10 diopters to plus 6 diopters with the additions that is shown here. I have no experience with the presbyopic IPCL. I'm still looking out for a patient that I can convince to do this. The preoperative assessment of all the assessments that you do, which are routine, the most important one is the anterior chamber depth and the white to white measurement. I think these are the two most important criteria. And of course, along with that, the intraocular pressure and everything else that we do, even in a cataract surgery. So coming to the anterior chamber depth. Now, how do you measure the anterior chamber depth? We usually measure it with an A scan, and depending on whether your A scan is measuring from the epithelium or the endothelium, you have to calculate your anterior chamber depth. For example, if it's measuring from the epithelium, you have to then subtract the pachymetry to get the actual anterior chamber depth. Of course, there are machines now which measure from the endothelium, so that will directly give you your anterior chamber depth. Now, vault is something that we measure once the surgery is done. However, I'm mentioning in the preoperative workup, because the vault is the distance between the physiological lens and the IPCL that you have placed inside. Now, the vault, the normal vault is between 250 microns to 750 microns in case of an IPCL. Now, the white to white measurement plays a very important role in the vault. So the white to white measurement, you can do it with the op scan, you can do it with an UBM, and you can do it with a digital caliper. However, the most accurate comes with a digital caliper. You then sort of just, compare it with the op scan and the UBM, and the difference should not be more than 0.5 or something. Difference of more than that, you should start probably doing a re-assessment again. So if the IPCL is too short, if you've taken that, if your white to white measurement was incorrect and you've made an IPCL that was too short, there is going to be less vault. And if there is less vault, then there is a chance of an anterior subcapsular cataract. On the other hand, if it is too long, the lens vault is exceeded, you will lead to an angle crowding, and there is going to be angle closure glaucoma. So the vault, the ideal vault is very, very important, and the ideal vault is dependent on the white to white measurement. The white to white measurement, as I said, it is taken by the digital caliper that gives you the most accurate one. Coming to the IPCL implantation, the dilatation has to be a minimum of 8 millimeters. You don't want it too dilated, because if you can't see the iris, where are you going to tuck your haptics? Topical anesthesia is preferred by most people, but believe me, I give a block. I'm one of those surgeons who don't like my patients moving their eyes even slightly. I do not like to use my vocal powers inside the OT. I'm a very quiet, silent person. So I like giving a block. I like my patient looking straight up. And the pre-op and the draping is just like you do in a cataract case. Axis marking ideally should be done with a slit lamp. If you don't have a slit lamp in the OT, you can just do the axis marking with the help of a torch or whatever you have. but the axis marking. Now, here we come to the difference between the IPCL and the ICL. In the IPCL, whether it is a spherical lens or a toric lens, your marking is only going to be 0 and 180 degrees. For the simple reason that the toricity is incorporated within the lens. You do not have to move the lens even slightly once you place it inside. So place it inside, leave it in the 0, 180 position, that's it. Doesn't matter how much cylinder was there, doesn't matter what the toricity is, just leave it in the 0, 180 position, which makes it so much more easier. I always believe less maneuvering within the AC, better results. ICL implantation. Now, this is the ICL. Now, if you look at this, this is the version 2 ICL. You can see that there are, first and foremost, why do I prefer the IPCL? Sorry. Why do I prefer the IPCL? Look at the foot. It's got 3 foots out there instead of 2. That gives more stability to the lens, less tendency for it to rotate. Number of holes, central hole is there, which now brings down the fear of, the pressure rising and everything. And the alignment of this, look at the 2 holes that is there on the optic haptic junction, those 2 extra holes. In this lens, it's on the left-hand side. That actually tells you the alignment of the lens. It's very simple. The surgeon always sits on the temporal side of the patient. So if you're doing a right eye of the patient, those 2 holes have to be on your left-hand side. If you're doing the left eye of the patient, the 2 holes have to be on the right-hand side. And if you follow this, there is no way you can put the IPCL upside down. So it's very simple. Loading the IPCL is another thing which is so simple because it is just like loading an IOL. I have found, and again, it must be maybe the fault is with me, but the amount of time that I used to take to load the ICL, in case of IPCL, I usually finish my entire surgery by that time. Because loading here is very simple. You just open the cartridge, fill it with saline and then with your visco, place the lens in the correct position inside, and see that it is completely within the groove. Before that, check for the orientation of the lens, close the cartridge and put it into the injector. There is nothing like, again, pulling it back or turning it around and all that stuff. It is just like you do your IOLs. So surgical technique, two paracentesis, put in the viscoelastic injection, make a clear corneal incision on the temporal side, inject the IPCL, go in with your tucker and just tuck the foot plates under the iris, do a very good visco aspiration, and you're done. So I'm just going to show you a video. This is one of my early videos. Why isn't it working? Just my luck. Unfortunately, my video doesn't seem to be working. It's not working. You don't even have that thing which comes in.
In the share screen, see the optimized sound and optimized video. There are 2 points. Please do it. I think this will work.
Optimize video.
Yeah. In the slideshow. Stop the slideshow for once. Try it. If it works, then it's okay.
I've stopped it. Now I go back to share.
Yeah. Share the screen again. There are 2 columns, 2 tick marks to be given. Optimize video. Is it there?
No, there's no optimized video. There's nothing.
Directly in the video, it was there.
It's okay, ma'am. We can carry on with this.
It's unfortunate.
We will be missing the great video then.
Where is the optimized video? Can I just take 1 minute to see if there is an optimized video anywhere? Is it here? Switch cameras? No.
The screen sharing menu.
Yeah, I have the screen sharing menu where it says stop the share. So I can stop the share and I see you back. And then when I go back to share,
share the screen again.
I'm sharing.
In the video column, it's there.
Where is the video column?
One second, I'll just show you. There are in the screenshot, there are one is share sound and second is optimized for video clip. There are two columns and lastly the share. Is it there?
No, it's not there.
Before sharing, you are seeing only the laptop. Before sharing, when you are trying to share, please have a try.
It's not there. I think I'm using an iPad, probably that's why it's not there. But I was not able to get somehow or the other connect my laptop.
Okay then. Okay.
Share, wait, share.
Okay.
Oh, so I guess I'm really sorry. I'll have to do without the video, but it's just like a video that Dr. Kasturi has shown. There's nothing very different about it. You make an incision from the side, go in with visco. The amount of visco you put in is important because ideally you should put in visco till you see the last strand and then stop. Because if you put in too much of visco, there is every chance that, when you put in the lens floats upwards and gets stuck to the cornea because of the amount of visco you have put. Also, sometimes too much of visco tends to tumble your lens within the AC. So the visco, the ideal amount of visco to be put is till you see the very last strand. And then you make a clear corneal incision and make the other side port because you need to aspirate it out again. And once you make the, again, like Dr. Kasturi, I would like to say that before you touch the eye, you first put your lens in place, because then you know that your lens is in place and everything's fine with the lens. And I wish I could show you the uploading of the lens, because this video had the uploading. When you upload the lens, you pick up the lens very gently with a MacPherson. These are very, very fragile, very thin lenses. I usually first put it on the palm of my hand and check out the orientation. It's a right eye. I see that the two holes are on the left-hand side. And only then I lift up the lens and put it into the cartridge. The cartridge, of course, has already been washed and visco has been put. And I put it into the cartridge. And while putting it in the cartridge, I make sure that, the entire lens is within the groove. Because when you put in the lens, and if a bit of the lens is, above the groove, then while trying to push it in, it might break. So you have to be careful that you put it inside the groove very carefully. When you close the cartridge, you typically hear a click sound. That sound is very important. You hear a click sound, you see a drop of visco that will come out. Watch out for that, because if that doesn't happen, there's something wrong about the way you put in the cartridge. Then you put it into the injector. Once I put it into the injector, I always make sure that I move the lens, so that to ensure that it is moving freely. So I do that. I turn the injector both ways, see that my lens is moving freely. And only then, once I am satisfied with the way the lens is within the cartridge and within the injector, it's only then that I proceed with the eye, making the side port and the entry and all that. And once I have done that, I then, take out the air bubble that is usually within the injector, because again, that air bubble also has a propensity to tumble your lens. It sometimes pushes your lens and tumbles it while you are injecting it. So you may have put the lens in the proper orientation, but while putting it in, your lens will tumble. So these are the things you watch out for. The technique while putting the lens is what I call the push and stop technique. I do not push in my lens at one go. I push and I pause. I push and I pause. Why do I do that? One reason is that when you push and you pause, then the lens gets time to unfold, and you can actually see for yourself whether it is unfolding in the right orientation. If for any reason you have doubt that it is not unfolding in the right orientation, that there is a tendency to tumble, you can always take it out anytime. Again, the one plus point of the IPCL among the many plus points that I have already mentioned is that they provide you two lenses with the cost of one. You rarely need to use the other lens, but just in case you need to use, you feel that this sometimes if there is any damage to this lens, or you feel perhaps the memories you've taken a long time, or you washed it again and you're not very sure how it will open, there is a second lens that you can fall back on. And believe me, as a surgeon, that gives you such a lot of mental boost. So once you put the lens
kindly
in,
conclude, madam. We are running late.
yeah. So
Thank
once
you.
you put it in, you go in and you tuck in the haptics, and that's about all. And you take out the visco very, very thoroughly. Once I see the very last bit of visco coming out, I always wait for another 2-3 minutes to see that everything has been taken out, and only then I conclude my surgery. And yeah, these were videos that were showing what happens if you lens stumble. So in conclusion, I will say that I think the IPCL is just as good, if not a better lens than the ICL. And besides the fact, it makes you feel very patriotic that you're using an Indian lens. Thank you very much.
Thank you so much, Dr. Doyle Biswas. It's a wonderful presentation. So, any Dr. Subhas Prasad, sir, is there, sir, if you want to add something to this? Yeah.
Very nice presentation, Dr. Biswas. Just I want to say that while doing the measurement with the caliper, now it is very much accurate, but I found that this is subjective. So we can use something which is very objective method, like if we can use the IOL master or anything else, but the only thing is that you have to validate your data. And what I found that if you decrease the length 0.4 millimeter, then it becomes almost equal to the digital caliper, the Werner caliper. So what nowadays I am not taking the patient to operation theater and measuring with the digital caliper, but I am doing all the measurement on my IOL master, and I am subtracting 0.4 millimeter from the this one, the white to white. That is one thing. Another thing that you told that you just see the two holes between the optic and the haptic junction. If you look at that, if it is on the upper side, suppose you are putting from the right eye, if it is on the upper side, it can never be upside down. I tend to disagree here. Even if the lens is upside down, it can be there on the superior part. What is most important is to just look at the bump which is facing on the leading haptic on the left side, which is the most important guide, which says that the lens is being inserted in the proper way. And those two holes obviously will be below the superior part that will be covered by the upper lid, and the leading haptic will be there. There is a bump there on the left side, in the leading side, and on the right in the trailing side. So that is the important guideline.
Sorry, sir, I didn't get you actually on this, because if I'm doing the right eye, and if my two holes are on the left hand side, my vault will always be towards the superior end. If my vault is in the lower end, my two holes will have to be on the right hand side.
No, ma'am. Even if like the lens is like this, even if you bring like this, these two holes will be on the upper side. See, if two holes are there, and if this lens is coming like this, then again the two holes will be the upper side.
No,
So,
sir, it will be there. No, sir.
No, sir, it doesn't happen that way.
In IPCL, it happens like this. In the IPCL, for the left hand side, it will be the holes will be on the right hand side, and whatever madam says is right. If it is on the right hand, if it is on the other side, then it is the lens is flipped. Lens is flipped.
I think I agree with Dr. Subhash. Let's have the slide of that lens and let's see
So
what
I can share. Excuse me, sir. I can share the video. If
we want that part of video which
yeah,
gives
I have the video.
Clear view of the lens.
Yeah, I have the video, sir. If you permit, I can share it.
Yeah.
Also tucked behind the iris, ensuring all the three curves of intracameral adrenaline was injected to dilate the pupil, and viscoelastics was injected to create adequate space for the introduction of IPCL. Another side port was created at 12 o'clock position. IPCL, with the help of butterfly cartridge, was injected into the intracameral space slowly with a controlled push technique, ensuring slow unfolding of the IPCL in the intracameral space with the vault facing up.
Please hold it there.
Yes.
Followed by
Which eye is this? 1 minute. Which eye is this? Is this the right eye or the left eye?
Yeah, mostly, yeah, it's the right eye. Yeah.
So if this is the right eye, your vault is up, your two holes are on the left-hand side. That's it.
Right eye.
This is the right eye.
I don't remember which is, but the vault is on the upper hand side only. It's up. It's the rightful orientation. It's not the reverse orientation.
It is right. This is
It
the
was
right
the right
orientation.
It was the right orientation. It is not the wrong orientation. I don't remember which eye it is, but it is it was the right orientation.
This is right eye actually. This is right eye.
This is right eye. This is right eye.
If this is the right eye, you're sitting on the temporal side of the patient. You have injected it. The vault is up. We can clearly see that. The two holes are on the left. So this is an absolutely, correct. And if you have to tumble it now, if for any reason the vault will come, no matter what you do, your two holes will come on the right. You cannot tumble this lens with the two holes being on the left. Whether you tumble it upside down, you tumble it sideways. The moment you tumble the lens, the two holes that are seen over here on the left-hand side will come to the right-hand side.
I think Dr. Doyle's, when she showed the lens, I think we should see the lens rather than, because this is very, very unclear. Because I also have doubt on this. Because the other lenses, they are very clear about the dots and holes and, the sides.
Sir, if the same lens is just flipped upside down, you see the two holes will again be on the same side on the upper side here.
Exactly. I agree with you, Dr. Subhash.
Yes, sir, I also agree with you. Now I'm introspecting whatever you say.
If you tumble it upside down, your vault will be towards the lower side.
No.
Your vault will never be up. If you tumble this lens upside down, if you have tumbled this lens upside down, which means that the vault, the curvature of the lens will have to be below.
Forward.
In order.
Yeah, that's what we are talking about upside down. The vault will be, the convexity will be posterior now.
Yeah.
Yes, the convexity will be.
No,
Dr. Deol, if you can show us your video in which you have the picture of the lens, that will become very clear. Because
but while
unloading time permits, you can see this video at the last.
We can have it in the end. But what Dr. Subhash is saying, I think is
last, and can you go to the next speaker because we are already running late.
You know what? We have only 40 speakers, and let us all discuss on this. This is a very, very important matter, right? Because what we are seeing is, the repetition of the same thing, every time. So this is a very important matter. Let us clarify it. What do you say, Dr. Subhash and Dr. Panoranjan?
Sir, I'm sure about this. Yes.
Sir, the basic concept that Dr. Subhash is trying to deliver, I think I also agree with that. So I think Dr. Deol, just think about it. I mean, just flip it out, flip it the other way around. It will be on the same side probably. I mean, I don't do IPL. I have to be very frank, but what I have heard, what I have seen from the discussion, if you just flip the lens, the vault will be reversed, but the hole will remain on the same side.
Yeah.
No, wait. I get your point. You are saying that if you flip it in such a way that your vault is down, you place your vault down with the convexity down. Okay, that is right at the beginning of the thing where you have to place it.
This is what Dr. Subhash is trying to drive.
Yes, I'm getting I totally get your point. What I really did not mention to say is that when you are placing the lens, you have to ensure that the vault is up.
If you maintaining the vault, if you maintaining the proper vault, the hole will be the same place. If you maintaining the wrong vault, man, that means the upside down, then the hole will be the lower side.
No.
Yes, because one thing what I mentioned. No. If you maintain while putting it into the injector, if you maintain the vault
orientation during implantation, if you always maintain the same orientation, IPCL, that the hole will be the upside. So that's why if it is it's a upside down in the eye, the hole will be in the lower side.
No, sir. It can be the same.
What
No, no,
One minute.
you
Can I just cut you?
not talking, Dr. Subhas, you are not talking about the upside down. You are talking about the whole 160-degree
Yeah.
vault of the lens. I am
Yeah,
not
upside
talking
down
about
is
this. I am talking about the wrong placement of the lens. That is the upside down.
It's the same thing.
No, 1 minute. Can I just come in
Either
here?
you
What
do the
Orupta is trying to
somersault
say.
or you do the upside down. It's the same thing.
1 minute. What Orupta is trying to say is that the two holes have to be always in the superior quadrant.
Agree.
Two holes always have to be in the superior quadrant. Now, I totally get your point, what you are trying to say. But to do that, to do what you are trying to say, while placing the lens in the injector, you have to place the lens with the vault down, with the convexity downwards. So only if you place the lens with the convexity downwards, only then can you have the lens, the two holes on the wrong side. If you are careful to see that the convexity is there, and believe me, in the IPCL, the new versions, the convexity is so much that you really
Doyle, if you even the convexity up, you can intentionally put the hole in the lower side.
Yes, you can.
But
you can put it on the lower side.
You have to keep in the mind where you put your hole in the cartridge.
And the loading.
You have to remember.
Yes.
Yes.
You have to remember two things. You have to remember two things: convexity up and the hole towards the superior quadrant of the eye, which means if you're doing the right eye, the convexity has to be up and the two holes have to be on your left-hand side. If you're doing the left eye, the convexity has to be up and the two holes have to be on the right-hand side. And believe me, if you're doing the version 2 of this IPCL, you rarely ever miss the convexity and the vault.
Not the place to do arguments. Let us move ahead.
Exactly. We are also we can play the Dr. Doyle Vishwas video at last. I think from the land of Rabindranath Tagore, we go to the land of Lord Jagannath. We have a very eminent speaker, Dr. Devi Aishwarya Das. She is a senior consultant cornea cataract at Agarwal's Eye Hospital. So she will be speaking on the most important today's topic. I guess it is the lens and know your candidate. Ma'am, please take over.
Good evening, everyone. So I'll be just talking about the basics of ICL, PHAKIC and ICL. Know your lens and know your candidate. I have no financial disclosures. So what are the indications? The classical indication is more than 21 years of age. Now, again, that is debatable, but I'm just going to first stick to the basics because we have listeners who are going to first be confident about the basics. Then they should have a stable refraction, that is change in refraction less than 0.5 diopter over 1 year. And for refractive errors, now the range of refractive errors that can be corrected is still lower, 0.5, but -3 was the initial standard. Previously, it was -6, and then it was lowered to -3. Then those who have poor tolerance for glasses and contact lenses, thin corneas, which is initially less than 480, rather a cornea which is thin for the expected amount of refractive correction. Like it could be more than 480 and still be too thin for a LASIK. And poor candidates for excimer laser, stable FFK, keratoconus, scarred corneas, or eyes with nystagmus, because difficult to do LASIK with the nystagmus. Now, what are the contraindications? Those who have active anterior segment disease, those who have a history of recurrent or chronic uveitis, cataract, previous intraocular surgery, glaucoma or an IOP, more than 21 millimeters of mercury on more than 2 recordings, then pre-existing macular pathology, retinal disease, iris or pupillary abnormalities, systemic diseases that can be associated with delayed wound healing. Now, what are the parameters of utmost importance in addition to LASIK, in comparison to LASIK or surface ablation? a wide to wide diameter is important, anterior chamber depth is important, and endothelial cell count is important. These are of utmost importance. So now I'm coming to the ASOCT picture just to have a brief overview of what are the parameters that we're talking about. The vertical, I don't have a cursor here. So the vertical line that you see, that is the anterior chamber depth. The longer one is the ACD. So, by norm, it is mentioned from the endothelial surface to the anterior surface of the lens. And ideally, it should be taken in an undilated pupil, because once you dilate the pupil, the lens, iris lens diaphragm tends to fall back. So you get a slightly over measurement of the ACD. And if at all it is taken from the, it's not mentioned endothelial surface, we have to ensure that it is from the endothelial surface. Then we can see the angle. The angle should be more than 30 degrees. And the cutoff point of angle crowding beyond which we need to do a PI, or we know that the patient is going to go for a glaucoma, is 15 degrees. And then you see the vault. Vault is the lower vertical segment, that is this distance from the ICL to from the ICL to the anterior surface of the crystalline lens. And the ELP is the one that subtracts this entire ACD. ELP is the one that subtracts the effective lens position, is the one that subtracts this vault from the anterior chamber depth. So these are the parameters that we are expected to follow up on every review. So now horizontal, most of them have been spoken about by the previous speakers. So horizontal visible iris diameter, or the wide to wide diameter, ideally using a IOL master or a digital calipers. But again, the pentacam or the OBSCAN can also give a roughly accurate. Pentacam tends to overestimate the diameter. OBSCAN is closer to the diameter. Ideal is a custom PHAKIC ICL sizer. Then this is used to calculate the effective lens position. ACD minus distance from the lens to the PIL, this is the effective lens position. So we have heard about how undersizing and how oversizing will affect the eye in future. So now anterior chamber depth of 2.8 millimeter for myopes and 3 millimeter for hyperopes is taken as the cutoff anterior chamber depth. There are studies which have shown that you can go lower down, but then that will need a even more accurate sizing of the ICL or the IPCL. Then endothelial cell count by standard should be more than 2,500 cells per millimeter square, more than 2,000 for people above age of 40, because above 21 is 2,500 cutoff. More than the endothelial cell count, what is more important is the health of the endothelium. We should do a proper clinical study of the endothelium and also the morphology of the endothelial cells. So we should not just stick to the endothelial cell count. Now, coming to the types of PHAKIC IOLs at our disposal, we have anterior chamber PHAKIC. We had rather anterior chamber PHAKIC IOLs, posterior chamber PHAKIC IOLs. Anterior chamber will be either angle supported or iris fixated, and the posterior chamber, of course, is a Vision ICL and other Indian variants of that. That is PHAKIC IOLs. They're not the ICL; they're called PHAKIC IOLs. We have the IPCL from the CARE group and the RIL from the Appasamy Associates. Of these, only the Verisys and the Vision ICL are FDA approved. So now, just a minute. I'm not able to see the right hand. Yeah, thank you. So now on my left, we have the Acrisov angle supported anterior chamber PHAKIC IOL, and on the right, we have the Verisys, that is from the Alcom Labs. Now, posterior chamber PHAKIC IOLs. This is the only FDA approved PHAKIC posterior chamber PHAKIC IOL. This is the Vision ICL. Now we have the Vision V4 ICL. This is again, Kasturi ma'am has covered most of it. This is made of collamer. So it's a copolymer of hema and porcine collagen. It is hydrophilic, flexible. It has a high biocompatibility. It is permeable to gas metabolites, and it adheres to fibronectin. So it is relatively less immunologically active. So the diameters of the optic can range from 4.9 millimeter to 5.8 millimeter, and 6.1 up to 14 diopters of myopia. And the overall lens length can be from 12.1 millimeter to 13.7 millimeter. And the central hole and all the other holes have a diameter of 0.36 millimeter or 360 microns. So the central hole is the addition to the Vision IC V4 series. So that effectively takes care of the pupillary block. So here we see the cutoff parameters for ICL. This I have got from the ICL people. So we have for myopia minus 0.5 to minus 18, for hyperopes plus 0.5 to plus 0.8, and it can correct a toricity of up to 6 diopters. So the ACD they have mentioned is a cutoff of 2.8 for myopes and 3 mm for hyperopes. And again, the white to white is 10.75 to 12.8 for both. But whenever we must remember that unlike your spectacle correction, when we are transposing, we choose to transpose to the negative form of the cylinder. But when we are going to go for the IOL par ICL par calculation, we need to transpose the cylinder into the plus form. This is probably because of the vaulting, that it is vault up. Now coming to the other posterior chamber phakic IOLs, these are not ICLs, so these are posterior chamber phakic IOLs. So the most commonly used are the IPCL and the RIL here in India. So these are hydrophilic acrylics, they are not colamers, but they have a higher range. IPCL has a range of plus 15 to minus 30 with a toricity of 0.5 to 10 diopters. It is obviously more economical as compared to the ICLs. And then we have the RIL from Appasamy. Now they have the V2, which also has a draining hole in the center. So this is the refractive implantable lens. It is hydrophilic acrylic. And again, it has a range from minus 2 to minus 30 in the myopes, and plus 1 to plus 6 in the hyperopes, and toricity from 1 to 6 diopters. Thank you. I've taken the references from AO and IJO. And yeah, that's it. Thank you.
So it's a wonderful presentation. So I think Dr. Tirtha, you can take over.
If I can make a point.
Please, yeah.
Yeah, if I can make a point, like Dr. Prasad was also saying, more than the orientation of the holes, we should be looking at the leading haptic. If we see the in the ICLs also, even I have had rotations of the ICL, but I have managed to rotate them back inside the antechamber, because the only one thing that I see is the draining hole in the leading right haptic. So if inside the I have seen, because these are very transparent lenses, thin lenses, so sometimes initially I did have rotation, but again I always look for the hole in the leading right haptic in ICLs. So if that is not there and is there on the left side, then intraoperatively I get to know that I have the lenses flipped. So on 2 occasions I managed to flip them back inside the antechamber. I have not had to go back and do an OCT to know that the vault is down. So that is one way, that is I think the most important indicator, the leading haptic, whichever one you do, IPCL or the ICL.
Thank you, ma'am. Now I would like to invite Dr. Jayanath, ma'am. She is senior consultant at Lions Eye Hospital, Silchar, Assam, and she will be speaking on beginner's perspective on phakic IOL. Welcome, ma'am.
And we can have the discussions after this. I think this is the last topic.
Visible? Hello, can you hear me?
You were not audible, Jayavedu.
Little louder.
Am I audible now?
Yeah.
Am I audible? My
Yeah,
screen.
yeah, Jayavedu. Yeah, you are audible now.
Okay. Good evening, everyone. All the previous speakers, they have nicely demonstrated and said everything about ICL and IPCL, how to choose your patients, how to select, and whom to perform this surgery and whom not to. So now I'll just, as a beginner, I would like to present how I began doing IPCL. I didn't do ICL, I did only IPCL. So once I went to AIS conference there, I visited the care group people. There they were telling about this toric lenses, multifocal lenses, and this IPCL. So I was already doing toric, multifocal, then this IPCL, this attracted my attention. Then they showed me the video how to do it. So I said, whoa, so easy. It is much more easier than this FICO. So why not to start it? Then I asked them, how should I start it? So they provided me with this demo lenses, which I can do in my cataract case before doing cataract surgery. So they gave me 2 samples like that. When I tried, I said that time I was not that much scared of doing it, because if anything goes wrong, then I can just have to remove that one and do cataract surgery. So I did it very nicely. I was so happy, so easy, I can do it. So like that, I go and gain confidence and I started my journey. And Radhika Daksina.
Your slides are not changing. Yeah, it is working.
So this is my first patient. He is basically a farmer. He was already using high power glasses. So he didn't want to wear glasses anymore because it was difficult for him to go to the field and do work with this high power glasses. And he had also tried with the contact lenses. He found that one to be cumbersome. Every day putting it, opening it, he was not able to cope up with that. So he was badly wanting without glass, what can be done. Then I said, it will be very costly, but can you afford it? Then I'll do it for you. He agreed. He said, okay, I'll manage the amount and then I'll come back to you. Once he came back to me, I was so happy to see that he'll be doing it, so I can help him. So it was just only the lens cost and the OT charges which I charged because I badly wanted to do this surgery. So next, does it be optional? So I did all the tests, his refraction, then white to white measurement was done with the digital caliper, PHAKIC was done, AC depth, keratometry, all the tests were done, and he was found eligible for IPCL. So this is the surgery, I'm doing it. Did 2 side port incisions, and then I did not notice that my assistant gave me 2.2 mm knife. So I had to struggle. I could not go in. Then I realized, then I changed the knife, just 2.8. Then I could go easily and place the lens in the anterior chamber. It was a smooth delivery. So just nicely and smoothly going inside the anterior chamber, unfolded. Now the haptics were tucked behind the iris. Now viscoelastic wash is given. But the last part, when I was hydrating him, iris was coming through one of the side port, but I could manage it. This is the end of the surgery at first phase, but lastly, I saw that iris was again coming to the side port incision. Then just release the speculum, make it little loose. And now I could do it. Iris was in place. Everything was okay. So this is the post-op. The slit lamp finding was quite okay. Eyes were quite okay, quite. And the CT showed good angle. And this is the second video of other eye of the same patient. Now I know that I have to use 2.8 millimeter this knife. So I could do it at the first attempt only. And then place the lens. Tuck the haptics behind the iris. To do the viscoelastic, again iris was tending to come out to his side port and main incision. And it was good. I'm trying to manage this one. And slowly aspirating out all the viscoelastic. Now I'm hitting the side port and main. Forming the anterior chamber. So this was the end of the first patient. And this is the post-op pictures. And this is the team who helped me, and somewhere behind also, but we were in front of the camera. This is the second case. She is a student. She chose for this IPCL, and all the parameters were suitable for this IPCL. And both eyes were done, and she was happy lastly to get her vision back without glasses. Thank you all. Thank you all for this vision story.
Wonderful. Yeah. Yeah, please carry on.
It was a wonderful presentation, ma'am. It was very encouraging for us to see that how you completed the cases, and so the wow effect is there once the patient has suddenly to get rid of glasses.
Yeah, patient feel very happy when they see that they are doing without glasses. This farmer who was so happy that he could not thank me for that, what he got after the surgery.
May we have some discussions?
Yeah, we can have the discussions right now. Yeah.
So Dr. Subhash, one question to you. Do you put pilocarpine after the lens implant, for any reason? You are
So
muted, Doctor. So you are muted. You are muted.
yeah. The same thing I just wanted to say that I put pylocopy at the end of the procedure just to see that the iris overrides over the PHAKIC IOL, so that the part of this is not actually tangled. Iris is not going behind that. In some cases where you have really upthrust in some patients in those situations.
Very correct. One more point to add, Dr. Subhash, that if you have chosen a larger IOL, even if you put the the pilocarpine, the people will never constrict. So then and there you know that it is oversized IOL. So that is very, very important. I agree with you. Very nice. Yeah.
Your tucking in also becomes difficult if you have a larger sized IOL, and you have to struggle a bit more if the size is not adequate.
Yeah, Ranjana, all the time we were missing you. We didn't hear you. So yeah, very nice.
One query I have with Dr. Subhas about white to white measurement by IOL master. What you suggested, just by subtracting 0.4 millimeter.
Yeah, sir.
Almost accurate, and you have stopped.
Yeah, I have found this giving me the good result all the time. I never had problem. Initially, in few cases, I used the digital caliper supplied by the ICL people, but later on, I found that it was cumbersome in the way that sometimes I myself was making some mistake in identifying the limbus. Sometimes it can be a little under, little over. And that too, we have to take the patient to operation theater just to measure it under the microscope. So I found that was cumbersome. So I did in some patients, I did just calibrated the finding of the distal marker with the IOL master. And then I found that 0.4 millimeter, it is overreading by 0.4 millimeter. So I started subtracting from the measurement, and then it is giving the good result.
So for beginners, I would suggest for lesser mortals like me, IOL master, it has ranged from 0.3 to 0.5. The difference is there. So those who are attempting ICL or PHAKIC IOLs, I would suggest that do a machine-based, and definitely do your caliper measurement as well, so that you can also estimate.
But Dr. Ranjana, caliper measurement is very subjective. I mean,
no, but you must corroborate. At least for beginners, I would suggest that you must
what
corroborate.
Subhas has suggested, if that is so accurate, if it can be validated.
Yes, sir, it is more or less accurate. It ranges from 0.3 to 0.5. The difference is there, and I think 0.4 is a good number.
Sir, I also take into account that actually I don't have pentacam, but I have a series topographer. So I take the reading of that also in account and then match all the things. Then.
Sir, I have a study on comparative study of all these. That is IOL master, anterior, pentacam, eye trace, everything. And I find that anterior, quite a bit resembles what I take the measurement in the digital caliper. It almost goes up to more than 95%. So if I'm busy or something like that, and if I'm not able to do it, I'll believe what anterior says. I have got no financial interest. Sorry. So it goes up to more than 95% accuracy. Take my words and you can try it out.
So far, no instrument can measure the sulcus to sulcus.
Yeah,
so what we get, the extrapolate the sulcus to measuring the white to white. So as Dr. Subhash said, I find my cases, the digital caliper and the IOL master difference is 0.5. And if you consider the anterior give the more accurate to sulcus in white to white measurement. So, but still I'm relying in my digital caliper, and I suggest a beginner to do the digital caliper if the ICL people supplied. But yes, if you do a lot of PHAKIC IOL, you can develop your own algorithm. So till you'll get Optopol is a new machine from Netherlands. We are developing the technology. We can measure the sulcus to sulcus. Probably then we can use IOL master, just subtracting 0.4 or 0.5, or it is better to do measurement with the digital caliper. But
Dr. Rajan
because
Gogoi,
you
I
have
wanted
you have operation almost 3 days a week. You can call your patient and you measure the.
So I just wanted to confirm from Dr. Ranjana Kumar ma'am again, like if someone is having IOL master, so I have taken the measurement in the IOL master, and then I have also done a digital caliper. So now which one should I follow?
You will see the whenever you
Digital
take the
caliper.
IOL master, it is showing the almost more than the you measured in the digital caliper. And it is better. It is really it's a 0.4, 0.3 to 0.5 more than you got in the digital caliper in IOL master. It will give the consistent result. Almost all cases, except very few cases where there is a broad arcus senalis, all that. But yes, you can take the IOL master reading subtracting 0.5.
So in other words, what you can do is you can take the IOL master measurement and then you can set the caliper at that level and slightly decrease it. So, the things will be quicker. The things will be quicker to do the digital caliper.
Okay, I understand. Thank you very much.
Dr. Rajan Gogoi, sir, if you want to add something, sir. So you are in a mute. You are in a mute.
Yeah, I mean,
Okay.
we do three things: IOL master, pentacam, and manual. But at the end, the IOL master and the manual approximate. But we always take the manual one. This is the lesson it was taught by the this ICL people. The good thing about ICL is that they take personal care of the lens to be sent to you. Many a times we ask for lens, they said that in this patient, ICL is not appropriate. So we do not do it. So that is why we like them. And when I started the ICL, I kept 4 patients ready, 4 eyes ready. And the person himself came to our hospital, stayed with me for 4 surgeries. And there he made me to believe that the manual one, we have the digital one also we do with the caliper. But the manual one, under operating microscope, the white to white is the most accurate. And that is what we take.
Just another clarification. While we are taking the manual one, we are talking about the horizontal white to white, or we also take into account the vertical white to white?
Horizontal.
Only horizontal.
Always. Dr. Narayan, I want to ask you a question.
No.
While tucking the haptic behind the iris, where do you hold the lens to push it? At the haptics or at the the thickest portion part of the IOL? What part of the eye to hold it to tuck it in?
That is you cannot touch the central optic. That is for sure. So we go to the periphery. We upper side. First we take the upper right hand, then the upper left hand, then the lower two.
No. The periphery has 2 parts. One is haptic part, which is much thinner, and just before the haptic, it is the thicker part. So do you hold it there, or you hold the haptic and pull it and then push it?
No, I do not understand your question. Yeah.
The IOL has a thinner part at the center, and then it becomes thicker at the edge of the optics, and then it again becomes thinner at the haptic, right? So if you have to push it behind the iris, where do you hold the lens? Is it at the thickest part of the IOL, that is at the edge of the optics, or at the haptic, you pull it and push it?
Haptic optics.
Dr. Arup?
IOL is hold the haptic. because yes, ICL you can even you can insert the haptic holding the thickest part, but in IPCL it is not possible. So I make it a routine practice to hold the haptic only, and the distal end of haptic as far as I can approach.
One very practical question, Arup.
This is a practical question, very practical question.
My next question is very practical.
Can I come in 1 minute?
Yeah.
Please, yeah.
Arup, I would like to differ with you. I used to do that before, holding the distal end. And I found it now that I've changed it to holding, the more proximal end of the haptic. In fact, below where the
proximal end of the haptic.
I find it easier.
Visible. Yes, easier.
Yes, I find it easier to tuck it in where the IPCL is concerned.
Yes.
It slips less and it goes in more smoothly.
Sir, there is a manipulator given by the ICL people that really pulls back the haptic, and then you can easily insert it. With IPCL, since there is a hole in the periphery, it's always better to don't go that far periphery. Otherwise, sometimes inadvertently you can hit the entry. So that
because
is
the hole is slightly larger.
Yeah.
Yes.
Practically speaking, sometimes the people become so large that you really wonder whether the haptic has gone inside or not. So what do you do to confirm it, whether the haptic has really gone inside?
Just rotate a little bit, and then that is one thing I do.
I rotate. I understand yes, it is gone under the iris. Is slightly rotate and again rotate the original position, then we can understand it is under the iris.
And what I found was, if you are in doubt, go ahead with other haptics, and the pupil slightly constricts, and by that time you know that whether it is inside or not. If it is not inside, you push it back again. So you don't keep on seeing whether it's inside or not, or don't have to try to rotate it, because if it's a toric lens, then you have a problem. So you go ahead with the other haptics, tuck it inside, and by the time people slightly constricts, then you will see whether it is inside or not. Do you agree with me, Dr. Narayan?
Okay.
A very nice topic and very well discussed. Thank you so much.
What kind of viscoelastic do you use, Dr. Subhas and Dr. Doyle and all, Dr. Narayan Bardoli? Which kind of viscoelastic?
I use 2% HPMC only. Any one of you doing it under irrigations also, hydroimplantation?
Okay. I think you should try the Hilon GB or Hilon. It's better. I think I am using.
Can I come in here once?
Yes.
Hilon GB would definitely be better. The only problem is that while removing it, you have to ensure that you remove it as a bolus and remove all of it.
It's come in the bolus. Yes.
In case you're not able to remove it like that, you're going to have a raised this thing. As for using hydro, I think a lot of people are using hydro, but I listened to Dr. Rajesh Sinha. He does it under hydro only for spherical, because when you're doing toric, especially if you're doing a toric ICL and all, and then you have to rotate your lens a little, there is always that chance that there will be shaffing of the iris if you do not use visco. So it can be done with the hydro for the simple reason that then you don't have to wash out your visco and there's no chance of the pressure being raised. But I think, if you do a very good aspiration, that really does not create a problem, especially now that all the lenses have a central hole. Raised IOP after a phakic IOL is, do a proper aspiration and it doesn't take.
That's absolutely right. And today's scenario, I am stop using pilocarpine also.
Absolutely. I don't use pilocarpine either.
I don't use pilocarpine.
By the time discussion is going on, we like to see the Dr. Doyle's video. Is it possible? You can have a try in the background.
I don't think so. I wish I could show you. And as Dr. Aishwarya said, and I'm so happy she has said this, that when your lens tumbles, and I have had 2 cases of tumbling lens. Believe me, lenses do not tumble if you put it properly. The only reason if it tumbles is if you have an air bubble which pushes it, especially if your lens is very thin, or sometimes if there's too much of visco. And what I have done, it is said that you can remove it very easily and, and then reinsert it, which is what happens in ICL. It is not so easy to reinsert, to take it out and put it in again in an IPCL, because IPCL usually has a very large diameter. So it's not all that easy. I have actually retumbled it within the anterior chamber. And I know all usually, and that can be done with enough viscoelastic put in. You can protect the lens.
I have never used IPCL. And what I learned, what I have heard that this, insertion problems are not there in IPCL. Loading is easy and insertion is easy. But it is not the case with ICL. ICL insertion is quite tricky. It takes sometimes a lot of time.
Yes, lot of time.
And while inserting also, you have to be very careful. It is a crucial period. So if you overcome these 2 things, loading and insertion, there is nothing. It is as easy as anything. And about the viscoelastics, we use methyl cellulose. Elon for the purpose that if something remains, it will be a catastrophe. So we use methyl cellulose and we do plenty of irrigation and aspiration, and that works very well.
I have a question, Dr. Devi. When you're putting the PHAKIC IOL, so most of the time you get a toric calculation. How is it very important to use a toric lens? Because the power is, let's say, -20, and the toricity is, let's say, -1.5 or something. Is it very essential to correct even this part of a toricity of the IOL?
No, sir. I find that I've never given IPCLs, PHAKIC IOLs. I always give ICL. So the size of the incision is usually a little more than 2 point. It's approximately 3. So effectively that takes care of about 0.75 diopters for me. A patient who is a 20 diopter myopia, if he has a residual of maybe say a 0.75, add to that, I don't think he'll mind it that much. So I see the need of the patient. If the patient is a low order myope with a significant amount of astigmatism, the proportion of the astigmatism to the sphere is important. Then I counsel for a toric ICL. But if the myopia is very high, with let's say -1 diopter cylinder or even a 1.5 diopter cylinder, I don't push for a toric. And there is also the economics part of it, because the toric is significantly higher than a spherical ICL.
Exactly. That was the point, because it is very costly. So we can cut down a lot of cost.
So I don't push for it. I don't counsel for it either, because I know
my dictum is if it is myopia is more than 12, -1 cylinder has no value. If it is more than 2, then we put toric.
It gets corrected with incision also, sir.
Yes, if it is 3 diopter cylinder, I'll always go for the toric IOL. But if it is 1 diopter, I always go for the standard ICL or IPCL. If it is -12. And today, nowadays, I've started ICL as a primary procedure, even -4 and -3 ICL without doing LASIK. Even I'll not mention the name, some of my colleagues, he opted for ICL, though he's absolutely fit for the LASIK surgery. And I implanted ICL -3 diopter. So if it is a less than 8 diopter, then I consider every cylinder as a consideration. But if it is more than -12, as Dr. Kashyap asks, is a -20 with a -1. Yes, -1 cylinder has no value. Then they can AC, they can correct it with the spherical equivalent with their calculation. They can choose the ICL as per considering the significant amount of spherical equivalent.
And I find that none of you have talked about the haptic getting stuck into the between the plunger and the cartridge. Nobody has talked about it. It doesn't happen to you people.
No, no. IPCL, Dr. Doyle very rightly mentioned that if you use that push and stop technique, it will not get stuck. The moment you try to insert the ICL in one go, then you have more chances of getting in trouble. So to be patient is the key.
It has got any scientific reason that you wait and push and wait and push and wait and push?
Because
scientific reason, the technique has not been, there's no evidence based, there's no publication regarding that, but personal experience, those who have, I mean, so far as I've been doing it, I see that it gives time for the ICL to open and to slide forward by the impact of the visco as well as its own relative movement. And then it's less chances of getting stuck into the cartridge between the plunger and the cartridge board.
I can share my experiences, when I put the lens inside and I take the, the blue stick, which is available with the Lucia company for the IOL implantation. I push it further inside and then again I put the methyl cellulose after that and then I push it. Then the chances of, the capture is much less. This is my experience and I'm trying it. So I'm not getting this capture anymore.
Let me ask one question. Last question maybe. Suppose we have done a good ICL and at the end, because of ICL power calculation wrong, you have a deficit of -2.5 to -3. What will you do now? Doctor, what will you do?
Go for bioptics. Yeah, you can go for laser vision correction.
Bioptics, yeah.
Yeah, bioptics.
That happened to me once. And since it was -2.5 diopter, I did a LASIK.
Yes.
It worked very well.
Yeah.
My question to Dr. Arup, have you used any ICL as a form of piggyback lens in the refractive surprise in your practice?
Not so far. Not so far. Dr. Subhash, if you see the design of Salcoflex, that's not the Salcoflex, that is the IOL lens of piggyback. This is almost the same design that the ICL has. The only difference is the thickness. So I preferred that lens because previously many before the Salcoflex, and sometimes that the Rena Salcoflex was not available for 2 years in India. That time many of us Indian doctor used that IPCL as a piggyback lens, but they have come with the Salcofix, the add-on lens. That is a design is almost IPCL. The only difference is the thickness is more. So I use that. I used yesterday. I used one add-on lens of care.
Is it available?
This is very good.
Yes, yes, and yes.
Orupta, the difference is the thickness. Also, the haptics are bigger. The haptics, you see, they almost look like elephant ears of the Salcofix, but it is very easy to insert. It is very easy to insert. Especially you have the confidence that you don't have a physiological lens below it, like you do in case of a phakic IOL. You're always careful about the physiological lens and the cornea. In the case of a Salcofix, all you have to bother about is the cornea, because below that you have the IOL below that. So there's no that you can't touch it and all that thing. So it's very easy. It's thicker.
Dr. Subar, how many you hyperopic ICL or IPCL?
I haven't done any.
Yes, I have started phakic IOL since 2007. So far, I did only 2 cases.
I have done
only
2
2 cases.
That is, your anterior chamber does not permit the
never comply.
never.
And that too doesn't have a central hole also.
Yeah.
That is
Yes.
another-
Don't have
You
a
have to
center
copy
hole.
that.
And the
But
lens
to
is
my
much
mind,
thicker.
the refractive surgery for the hypermetropia, they're never successful. Whether it's you talk about LASIK,
Over
whether
the
you talk
year,
about contact lens, even the contact lenses, and they're not, people are not happy because sometimes they'll say that they see better, sometimes they don't see better. So they are not the good candidate. So very correctly, just done
It is
one.
rarely
So
demanded
one
also.
unhappy
Yes.
patient.
Yes.
Over the year,
Hydrops rarely demand this surgery.
Can I ask a
2000.
question, please?
I think,
Can I ask a question?
be the number one choice. This should be the number one choice for the refractive surgery, not the LASIK.
Arup, I have just one question. While pushing visco, do you try to push some amount behind the iris also?
No. It is very difficult to push under the iris because it's you can touch the capsule of the anterior capsule. So if you displace the iris little bit with the Helon-GV, but viscoelastic with the HPMC, it should not be tried. It should not be tried to lift the iris as we do in the during the Malugin ring or other pupillary ring, but it should not be tried because you can touch the inadvertently the anticapsule.
Very true.
Orupta, I have a question for you. Orupta, can
We
you
have
hear me?
discussed a lot of DRE, this PHAKIC IOL over telephone. Yes.
Orupta, yes, Orupta and I always discuss our cases over the he is my
Actually,
guy.
I hate to interrupt, but like, what is the opinion of the house? Should we end it or should we stretch it further? Dr. Swaraj Bhattacharjee and President Sir, Dr. Gupta, please take a call.
As per protocol, we must end up
I think
with
we
your
should end up.
sweet vote of thanks. But
It's a very nice discussion, a very lengthy discussion.
Great discussion. Let it continue.
Wonderful session. Yes.
Great discussion. Great discussion. Let it continue if it does.
The coordinator is going on car.
Have one question.
No, it is. I don't have a problem personally, but it is fine. But I
It's
have to
lovely.
go.
It's one of the best webinars I've
Yes,
heard.
I think we should conclude.
This was a
Like
great
the
discussion,
Clarnet,
actually.
the
really.
Clarnet people will be over my head. Like you said, 1.5 hours, and now it's 2 hours.
We must conclude. I think.
Before you go,
Yes.
I will show you one thing. Just two minutes. Okay.
Yes, Dr. Narayan. Yeah, please go ahead.
Do you see me? This is the book I have written in
Wow.
Assamese.
Being a technician, Pachaputi. Wow.
So
Good.
this is I have written in Assamese. And this is for
Bengali, Nanda, you know Bengali very well.
So this is Assamese Bengali saying.
Congratulations, Naranda.
So this is the first book in Assamese on medical techniques. This is for the vision technicians. So this book is now approved by the State Health University. Today it has come from the press.
Good.
Congratulations.
Thank you. Congratulations.
It is great. It is great, sir. Congratulations. Just I'd like to have a word from one of the chairpersons, Dr. Shubhra Kinkar Goswami, sir. Sir, please.
Yeah, it was very nice discussion actually. 2 hours, I think it is not sufficient enough. Even then we have to wind up. So I learned a lot from the discussion, though I'm not doing ICL, and hope to do it within a short time. Thank you very much.
One word from Dr. Rajen Gogoi, sir, please.
Hi. Yes, Havanti. So I think it was a very good discussion. Almost all the things about the PHAKIC also we discussed. But I think one or two points are missing here about people. So nobody has talked about the pupillary size before implantation of ICL or IPCL. So what about what are the? I want to know about from the speakers. How many of you are looking for the pupillary size? Because size matters. If you have a bigger scotopic pupillary size, it is said the glares are there. So that should be mentioned, I think, by our speakers. And what about the corneal topography? Topography should be done in every cases of ICL or not? Those things are to be actually also mentioned here.
Dr. Devi, if you could answer that. Yeah.
Yes, sir. By practice, we do a topography for all patients whenever we are planning any refractive procedure, because that sometimes the borderline cases which can go for either LASIK or go for ICL. So by default, we do topography in all these patients. We need to do a topography in fact, because if you're not ruling out any underlying FFK or then it's very difficult. You need to do a topography.
Can I say?
It's mandatory.
Can I say some words?
Yeah, sure, sir.
Yes.
Sure, sir.
I routinely do topography also, but that is not very important as far as ICL or IPCL implantation is concerned. It is much more important when the patient has undergone C3R or the patient of keratoconus, where you want to see that the refraction is stable, cone is stable for last 1 or 2 years. Then you can plan for ICL or IPCL in those patients. In those situations, it is very, very important.
True.
Dr. Doyle, would you like to add something about the pupillary size as mentioned by Dr. Rajan Gogoi, sir?
Size, it is true that if the pupillary size is large, there is a question of glare and all. As far as IPCL is concerned, I believe they customize it, the haptic, and they customize it. But as a routine procedure, when I'm counseling my patients and even when I'm taking the consent, I do tell my patients about glare and the problems they might encounter while driving and all. So that is something that I counsel them even while I talk to them prior to doing the IPCL. But I have not had the occasion, but care group has told me that that case of where you have a very large size pupil or something, they customize their lens accordingly. So we do note down the pupillary size while doing the pre-op workup.
So can I come in?
Yes, please.
So most of them are young patients, so we sometimes cannot suspect if they have got FFK there. So if you're doing an ICL based on today's just refraction and his refractive status, you'd never know which one of them is an FFK and is going to blow up into keratoconus in some few years. So in all these patients, because they're refractive patients, I think topography is a must.
I do a topography in all my cases,
yes,
every case.
So because the refractive case, they are not beyond 40, in which suppose even if there are keratoconus and they were 38, then maybe we don't expect that will progress. But if he's a 20-year-old and he has an underlying FFK, there's no way we can know. And
Can
today
I make if patient having the high cylinder, it is better to do
no, sir, even patients
even low cylinder.
Even patients low cylinder, they have FFK, sir. We have seen so many cases.
Only
sir.
power. What is the logic of doing? Yes, I do the pentacam, the age and every cases are doing the last almost 16 years. I find very, very few cases we opted for the ICL is turned out into the keratoconus.
So the moment we have to say that we have to do topography, in that case, you are restraining persons who do not have access to a topography machine from doing IPCL or ICL. So I think that restraining thing should not be there.
No, but since we are talking on a forum and there are speakers, there is a section of the audience which is learning from us, I think we should teach them the right thing. Because we are speaking from a forum. So I think we should tell them the right thing. So otherwise, again, what happens is misuse of a technology will give rise to a bad name for the technology. That is why LASIK has got a bad name, because we are overdoing things in certain cases. So we should tell them the right thing. So I think because we are speaking from a forum, we should not preach them to do any refractive surgery without doing a topography.
No, whether you are doing the topography or oculizer and seeing whether the patient has got a keratoconus or not, you do treat the keratoconus, but ultimately you have to do the IPCL. I mean,
if a patient has a keratoconus, sir, if a patient has a keratoconus, we are not bound by any means to do an IPCL. We have to treat the keratoconus to the patient. So, and only if it's a very stable keratoconus, there is a very small segment of that patient in whom I go for ICL for them. I have gone for ICL in 2 cases. So, when a patient has a keratoconus, our primary duty is to treat that keratoconus, not to give him an ICL.
We are talking about the refractive surgery. Refractive surgery in cases of keratoconus. You treat the keratoconus with C3R, and then at a later date, you go ahead with the.
Yes, sir, it has to be stable. I'm not saying don't do it, but it has to be stable. If he has come in 2020, you're doing a C3R in 2020 in a 20-year-old. I'm not going to do an ICL for him in 2021. I'll wait for 4 years, 5 years till he's 25, 26, and only then give him ICL offer.
So, Aishwarya, the patient came to you with the minus 12 diopter of spherical without any cylinder, and his or her age is 24. That power is stable for 4 years, and you can clinically exclude the chances of keratoconus.
Yes,
I agree with it.
Yes,
yes, that is there. That is there.
Yes.
Orunta, that is where it is stable for 4 years and the cylinder is not increasing. Suppose I have a minor cylinder and the teaching is that, it 1 year, 1.5 years, it is stable. I have come across a few patients who show a posterior elevation, show a, foemifusce or something like that. So I don't know whether this is going to progress. So immediately I cannot go for an IPCL and ICL. I will wait, see if it progresses. If it progresses, I consider it as a keratoconus. If it does not progress, yes, I will go for an IPCL. And then also if it's progressing or whatever, I will first treat for that, for the keratoconus, and then go for an IPCL. That is why I think that it is important that we, get the picture of the corneal surface and the posterior curvature. 4 years you waited, that is okay, that is fine. But you always don't wait for 4 years.
Well, if patient have a stable refraction, don't have
For how
any
long?
normal
For how
cylinder or very high cylinder, only spherical per, we can go ahead with ICL or IPCL phakic IOL without doing topography.
Okay, tell me something. A patient has a minus 2.5 cylinder.
Okay,
Okay, or minus 2.
we will keep this discussion alive in a later date, maybe. And I think I have to wrap up the session. I'm so happy all of us have really participated in a big way. And the Clarinet were very supportive and very helpful. So first and foremost, I'd like to thank the Clarinet team for making this possible. And then I thank our president, Dr. B.N. Gupta, sir, Secretary, Dr. Swaraj Bhattacharjee, Chairman, Scientific Committee, Dr. Sabyasachi Patnaik. Then my deepest regards to the chairpersons, Dr. R.C. Meher, sir, Dr. Ranjana Kumar, ma'am, Dr. Shubhra Kinkar Goswami, sir, Dr. Arup Bhomik, sir, and deepest regards to the program coordinator, Dr. Debashish Das, who has given me this opportunity to be the state coordinator and get this bunch of great speakers together on this forum. My thank to my younger brothers, moderators, Dr. Tirthojit Moitro and Dr. Mayur Dattobharali.
Dr. Praveen.
Dr. Praveen, thanks to the esteemed panelists, Dr. Narayan Bordoloi sir, Dr. B.P. Kashyap sir, Dr. Rajen Gogoi sir, Dr. Ashok Nanda sir, and Dr. Subhash Prasad sir. And lastly, and certainly not the least, the speakers who have made this meeting alive and given us a lot of insight on the topic of phakic IOL. Why I chose this topic in the first place was because I wanted that maximum number of general ophthalmologists should start or should have some insight into phakic IOL practice. It should not be a no-touch zone for the cataract surgeons. So now all cataract surgeons can become refractive surgeons as well. So my thanks and gratitude to Dr. Kasturi Bhattacharjee, Dr. Doel Biswas, Dr. Devi Aishwarya Das, and Dr. Jayanath for being great speakers. Thank you very much.
Thank you, everyone.
Thank you, Doctor. Just one more minute. Thank you, Dr. Homanti, for the beautiful vote of thanks. Now we will have our next meeting, Voice of East, in the month of August from Odisha on the glaucoma. Now, and thank you, Clarinet people, for arranging everything. And thank you each and every participants who have been there in all way. Thank you so much and good night.
Thank you
Over
so
to
much,
Clive.
everyone.
Good night, everybody.
Thank you so much,
Bye.
everyone. Good night.
Good night.
Good night.
Good night.
It was nice seeing you, Ranjana. Come more often.
Thank you, sir. Yeah.
Okay,
Thank you,
bye-bye.
sir.
So with all your due permissions, we are signing off for today. Thank you so much.
Thank you.
Bye-bye.